Welcome to Hernia Talk Live. You're here on another Tuesday, what we call Hernia Talk Tuesdays. For those of you who know me, I'm a hernia and laparoscopic surgery specialist. You can follow me at HerniaTalk on Twitter and Instagram. Many of you are joining us on Facebook Live on my homepage at Dr. Tofi. And once we're done with this session, I'll make sure that I share it with all of you on my YouTube channel. This week, we have a fantastic friend of mine all the way from Ghent, Belgium, Dr. Filip Muysoms. He is a very talented surgeon. He is one of our very well-known and well-respected leaders in hernia surgery, and he's really become one of the world leaders in robotic surgery. I've had the pleasure of visiting him at his hospital in Belgium just last year before we were not able to travel. So I'm very happy to see you, Filip. Thanks for joining me.
Hi there. Happy to be here.
I know that we have viewers also from Europe, so we changed the time for this Hernia Talk a little bit earlier so that I don't have to interview at 3 o'clock in the morning, but also it's still late at your time. It's about, what, 9 p.m.?
Yes, 9 p.m. The hour changed the last weeks.
Yes.
Summertime to winter time, so it's a bit confusing at the moment.
Yeah, we fell back 1 hour too. So thank you for joining me. Dr. Muysoms is a general surgeon in training. When did you start using the robot?
So actually, September 2016. Actually, I've been a hernia surgeon and visiting congresses, being in boards of the Hernia Society for almost 2 decades now.
Yeah.
In 2016, I visited the American Hernia Society and seeing the use of robots by hernia surgeons, which before that I would never have thought that I would embark on that. But because my hospital bought a new robot recently and they had access time, and they actually asked if we had any value for it. So 1 and 1 is 2. Me being a hernia surgeon, seeing what they do in the US, started doing hernia surgery with the robot, getting trained in a proper way, getting proctored by some well-known US surgeons during the start, and really looking really also on a scientific level, trying to find out how does this robot potentially benefit surgical care for hernia patients. That's the goal, and that's a trajectory. We're now, 4 years later, and I think we're almost halfway. We still have a lot to prove, but okay, we're working on it.
So the robot we're talking about is the Da Vinci robot. It is a product of Intuitive Surgical. It's actually a company in my state of California, a couple hours north of where I live, which is pretty cool. The CEO is a really cool guy. He's an engineer. And what I heard is that he actually wrote all the code for this very complicated robotic platform, which we use for surgery. I started getting trained in it in 2013. And it really penetrated the US market first before it moved on to the European market. It's very expensive. And so it's often more difficult to introduce the more expensive technologies in a more of a socialist type healthcare system like the Europeans have. But your hospital is very nice. I really like it. It's very beautiful. You walk in, it's very open and white and bright. It doesn't look like a hospital. It looks like a really nice
airport.
Yeah, it's not as warm as like a hotel, but it's not as cold and kind of impersonal as or like weird as a hospital. It's very nice. What's the name of your hospital?
It's called Maria Milares, which is like a Dutch name of the Saint Mary. So it's derived from a Catholic organization. So.
Yeah, and it's very very beautiful, very nicely run, very efficiently run. I was taking videos last year. You remember? I was videotaping how efficient your operating room was. I think we did like 7 operations in one day, including an
Yeah, we do
emergency
have
surgery.
amazing turnover times, which
Yeah,
I do a lot of case observation. That's a remark we get every time.
yeah.
So,
I had to
but
think about
that's everybody. That's nursing, anesthesia, even the cleaning people. That's just the way. It's like a working environment, which it's not always like this in Belgium or in Europe. It depends a lot of where you work. And but I'm looking to work at a place where the dynamic is such that everybody's like proud to have a good turnover and a good efficiency level. So, and it's not a
so.
coincidence that the two leaders of the hospital, director of the board and the director of the hospital, are both engineers. So they are really also, for them, it's
Process
also like
oriented.
if engineering tools, if new technology comes into the clinical practice, that makes them a bit proud. So it's a bit easier to convince them to use new technology.
So just to clarify, the robot is a technology similar to other technologies like endoscopy, laparoscopy, etc. You're still doing the operation. Can you just talk about the transition from laparoscopy to robotics and how much control you have over the operation?
So basically, what I always say, it is laparoscopy. So
Yeah.
I will always, if I write a letter to a general practitioner or I announce an operation, I say robot-assisted laparoscopic surgery. It is laparoscopic surgery, but you use a different tool. Uh, so the difference obviously is that in conventional laparoscopy, you are standing next to the patient, you're holding the instruments in your hands, and the camera is handled by another person, which is usually your assistant or resident.
Yeah.
Uh, while when you're in the robot, you're controlling the instruments, but indirectly through the robotic platform. But still, you are in control. The good thing is that you're not only controlling your two instruments, you can even add a third one if you want, because you have 4 arms, and you can also at the same time control the camera. So you're much less dependent on other factors, which the flow of the operation becomes different. But you're still in control of everything. Every motion is controlled by yourself as a surgeon, obviously. That's one of the mistakes. Sometimes you see patients and they say, "Oh, I don't want to be operated by a robot." That's a mistake. It's, you could call it a master-slave relation. So the surgeon is the master controlling the. It's not that good comparison, but the robot really does what you want it to do. But it takes, of course, some training to get to a level where you become firstly proficient, firstly safe, and secondly proficient, obviously. That's true.
Yeah. So I have also patients that say things like, I want you to do the operation. I don't want the
Yeah.
robot to do it. And you're right, actually, we have more control over the entirety of the operation with the robotic platform than with laparoscopy, because with laparoscopy, you have at least one other person involved to hold the camera at the least, and you only have 2 hands. You can add extra hands, but that's an extra person, whereas you can manipulate the camera and all the instruments. And then what I found is, so I was initially not a big robotics fan before 2013. There were multiple opportunities for me to get involved in it, and I just didn't do it because I'm kind of a purist and I was really good at laparoscopy. And I felt that the robot was for people that weren't really good laparoscopically. In other words, uh, I felt that I don't need the robot because I can do everything laparoscopically. And that idea changed when I saw that the robotic platform allowed me to do operations that I actually couldn't do laparoscopically. I didn't know about that until more surgeons started using the robotic platform for more advanced operations. Like an inguinal hernia, I still prefer to do those laparoscopically. I think the scars are prettier and smaller. But like mesh removal, we looked at our our studies, doing mesh removal is much better outcome, we feel, uh, with the robot than laparoscopically, because there are all these really like intricate procedures like the femoral vein and so on. You have to take the mesh off. Like the optics you get from the robot is so much better than with laparoscopy, even though we have like, I think we have like 4D now with laparoscopy, but with the robot, it's still much better. It's like working with a microscope. How do you feel about that? Do you also feel like that's been one of the booms of robotics, is it makes you do more than you could laparoscopically, even if you're like a fantastically gifted laparoscopic surgeon, which you are?
Well, firstly, before I went on the robot, I had the same feeling. I'm a laparoscopic surgeon, been like that for since 2000. And actually, I trained a lot of people doing laparoscopic groin hernia. People would come and visit me to see how we did that. So I was well proficient in that. But still, looking at how you do it robotically with the enhanced visualization, the wristed instrument, it still takes you to the next level. And basically, there's another factor that it is difficult in a straightforward groin hernia to prove probably that you're benefiting the patients, because the patients are doing so well after conventional laparoscopy as well.
Yes.
But indeed, there are these cases when we looked at our data. I keep track of all my data in the registry.
Yes.
And I saw a decline of open surgery from about 17% in about these 3 years to about 6%. And that is indeed these patients that we would do open, like after prostatectomy, mesh
Yes.
removal, or recurrences after previous mesh, large scrotal hernias. These are hernias that I would take open, and we are now taking them robotically.
Totally.
Minimal invasive. And that's probably where for groin hernias, there is a benefit. For the large incisional hernias, the gap is wider. Why? Because, as you said, we are doing now wide incisional hernias, minimal invasive with the robot laparoscopic,
Yeah.
Which we couldn't do, which before we did open. So in these patients, there is a hospital stay that goes from almost a small week, 5-6 days, goes down to about 1 to 2 days. And that's what happens when you take them minimal invasive. And that is very difficult, or never say impossible. There are some wizards in the world doing that laparoscopically, but
Yes.
most surgeons cannot do that very well laparoscopically. And the robot platform helps them to do that.
Very true. We have a live question. This patient had bilateral inguinal hernia with mesh done laparoscopically. He's now considering, I assume it's a he, now considering removal of mesh, and the surgeon recommends that the mesh removal be done robotically. But he had read that the removal surgery should be done the same way as the placement. So if you had laparoscopic mesh placed, the removal should be done laparoscopic, and when you have an open mesh placed, the removal is also done open. Is it standard to have the removal done with a robot if the original surgery was done laparoscopically? And then what's your answer to that?
Well, basically, the thing is that if you do laparoscopic surgery with mesh, your mesh is behind the muscles. So if you're going to redo that open, that's going to be very difficult, because you have to go through all these muscles to arrive at the mesh, and your view is not well. So if mesh removal in the preperitoneal plane, so behind the muscles, is needed, certainly a laparoscopic approach is better. The difference, the distinguishment this patient has to make is that robotic surgery is laparoscopic surgery.
Yes.
And if somebody proposes we want to do this robotically, the reason why this surgeon say we want to do robotically is because of the platform he has or she has, better view, better visualization. He has wristed instruments, better control of the operation of the operating field to remove that mesh. So removal of a mesh that is placed laparoscopically, if you have availability of the robot, that would certainly be my choice. And robotic surgery is laparoscopic surgery.
Yes. Yeah. So the way I think of it is, they're perfectly interchangeable. Every single operation that's done laparoscopically can also be done robotically. The size of the incision may go from like 5 millimeters to 8 millimeters. In some situations, the placement of the incisions may be a slightly higher up or further to the one side with the robot than with the laparoscope. But in general, they're both considered minimally invasive operations, and they're both considered to have usually better outcomes, either shorter recovery time, less pain, or better long-term results than their open counterparts. So as surgeons, especially general surgeons, hernia surgeons, in general, of course, there are exceptions and everything has to be tailored to the patient. In general, if you can do something minimally invasive, which is either laparoscopic or robotic, then that tends to cause less injury overall to the patient, and their healing is easier than open. So if someone says laparoscopic or robotic, we do use those terms sometimes interchangeably because the technique is very similar. The other question that this patient is asking is, they would want to stay away from the hospital, and the robot is in the hospital. They prefer to stay in like a surgical center setting. What are your thoughts about, do you have robots in surgery centers?
No, well, in Belgium, we have hospitals and we have nothing outside of that. You do
That's
have
true.
for certain niche like plastic surgery or eye surgery. Sometimes you have centers that are outside of a hospital or separate from a hospital.
Yeah.
Plastic surgery because it's not reimbursed, so patients pay everything, while all the other surgery is usually done inside a hospital, which can be a daycare facility. So patients come in and they don't have to sleep there, but it's still within the hospital building usually. So we don't have, certainly not in Belgium, we don't have any private healthcare separate from the regular healthcare really,
Oh, you
because
don't?
there
Okay.
is not really need for that. We have good quality, I think, and there's no waiting list. We don't have any waiting list, and the reimbursement is the same. You can go all over Belgium if you want to have your groin hernia repaired by a surgeon that is on the other side of Belgium. That's your choice. You have complete choice of that. So there would be no value actually to invest in a completely private hospital environment in Belgium. That wouldn't work. People would not go there. Why would they go there to pay everything themselves if they can get good care without waiting lists at another place?
That is so interesting because the United States, it's different. Obviously, we do have we don't have socialized medicine. We do have certain government sponsored medical insurances, as well as locally supported, like what we call county hospitals. But most care is done in a private setting of some sort. And so the economics is very important, which is why we have surgery centers. Doing the same operation in a hospital versus a surgery center, because of the different ways they're regulated and their staffing. It's much cheaper to do the same operation at a surgery center. So oftentimes we prefer to do them in surgery center because it's kind of like a lower volume and less unhealthy people. The healthy people can often get patient surgery, and so we do it at the surgery center. But a robot is very expensive. The robot we have 7 robots at Cedars-Sinai. I think we're getting one or two more, and the value is like over $2 million per robot. The amount of operations you have to do to pay for a $2 million robot is ridiculous. There's no way a surgery center can afford to buy a $2 million robot. So it's very kind of financially lean compared to a hospital. So even though I'm pitching to get a robot for my surgery center, I think in the United States there's less than a dozen in the entire United States, less than a dozen robots that are in a outpatient surgery setting. So yes, you would have to get it done. If you want robotic surgery, most likely you'll have to get it done in a hospitalized setting. So the flip is not true though. So there are operations that pretty much can only be done robotically, with few exceptions on like surgical, like really technically gifted surgeons, but pretty much the above average and below average surgeon, there are situations where you cannot do it laparoscopically, but you can do it robotically. And I think that's been one of the benefits that I've seen in my practice. I'll give you examples. So patients with really wide hernias, those are almost always done open, but there are techniques like the TAR that can be done robotically. There are some surgeons that do it laparoscopically. It's very technically challenging to do so much manipulation and sewing, whereas sewing with a robot's super easy. In my practice, I remove a lot of mesh, and I also offer a lot of non-mesh repairs. So we just published our results of non-mesh inguinal hernia repairs with the robot, because you can sew in this plane, you can sew the hernia closed with no mesh for inguinal hernias, where we call that the robotic iliopubic tract repair, RIPT. Whereas laparoscopically, that's a very difficult angle because you don't have the wrist movements on laparoscopic instruments. We call them chopsticks. I don't know if you call them chopsticks. They're like straight. So it's hard to sew. It's like sewing with like 2 knitting needles. And then the third operation I prefer to robotically is the mesh removal, but I can do that lap too. It's just, I think, better robotically. And the fourth one is diastasis closure. I know that can be done lap too, but it's so much easier to do a robotic plication and closure of the diastasis for people that have a hernia within a diastasis. And I think gives a much better outcome. Are there any favorites that you have that you prefer the robot for?
Well, I think obviously I'm a big fan of Robotar because robotic tar, which is like it's an acronym for a technique where you divide the different planes of the abdominal wall, trying to bring it wide hernias together, which is hernias
Yeah.
bigger than 10 centimeters in width. So quite big hernias that otherwise you would do open. And now we're doing a minimally invasive. And these patients are doing so much better after this minimally invasive technique. This was for me the trigger to say, okay, this is going to come.
For me too. That was the trigger too.
Sorry?
That was my trigger too. It was the TAR.
Yeah.
It was the robotic TAR. I couldn't imagine that that's something that they go home same day or next day, whereas open surgery, they need like 3 to 5 days in the hospital.
Yeah, that's the first patient I saw. I said, okay, it's coincidence. When I went back and back and back, every time challenging myself.
Yeah.
And of course, it's not magic. If you can still have complications, you know. If you make a hole in a bowel, you don't see it. Whether you use a robot or a laparoscope or open, your patient is in a lot of trouble.
Yes.
So it doesn't prevent you from having complications. But on the other hand, if you are able to do these complex surgeries by minimally invasive technique using that robotic platform, the gain for the patient is huge. It's really huge. Pain-wise, mobilization-wise, hospitalization, much shorter.
So I know you do a lot of robotics teaching all over. You travel so much for that before COVID, obviously. So the other thing that I know has happened in the United States, which I assume has happened elsewhere, is there's a lot of surgeons that don't offer laparoscopic surgery, especially for like inguinal hernias and many ventral hernias. It's the learning curve for a laparoscopic inguinal hernia is pretty steep. It's something is 250, something is 500 cases or more before you start getting a plateau in your complication rates. in the United States, what we are seeing is because the robotic platform is so much more intuitive and easier to use, that people that were never able to offer laparoscopic hernia repairs to their patients are now offering the robotic hernia repair instead of doing an open mesh repair, which has much more risks of chronic pain and recurrence relative to laparoscopy. So people are going from open straight to robotic. Do you see that?
No, it's not. It's not really the people that are training on the robotic platform at the moment in Europe
Yeah.
are mainly also experienced laparoscopic surgeons.
Oh, okay.
The penetration of laparoscopy for groin hernia repair compared to open is very, very heterogeneous across Europe, because you might think from the US, that's the United States of Europe, but there's a lot of cultural differences also in training. A lot depends on the key opinion leaders. There's some Scandinavian, you have different types of laparoscopic groin hernia repair. You have the TAPP, transabdominal. You have the TEP, which is preperitoneal.
Yes.
Basically, it's the same operation, but it's more like an attitude or where you were trained or personal preference of the surgeons. But you have some countries in Europe, like I think it's Sweden, that almost everybody's doing TEP. In Germany, it's more TAPP. In Denmark, it's also TAPP. And that's because of key opinion leaders, the people that were on stage and were training other people to show them these new laparoscopic techniques in that country were doing one or other technique.
Right.
It's very, very strange how it diverges. But also, I think in Belgium, it's about 50% of groins. That would be my estimate, is laparoscopic, which is huge. Higher than many other countries.
More than the United States. Yeah.
Yeah, but you see a big uptake in the Scandinavian countries because they have a lot of registries there, so they see their data in Scandinavia, and they start realizing that laparoscopy is really benefiting the patient. So you have a move certainly in Scandinavia towards more and more adoption of of laparoscopic groin hernia repair. But the people I train at the moment are usually well-trained laparoscopic surgeons as well.
I think that's a good thing. I think it's a little bit odd to skip the laparoscopic learning curve and go straight to robotics. I'll get to that, to some of the questions we have. So one question we had was, how long has a Da Vinci robot been used for surgery? I think decades, right? Almost 30 years?
Well, I think the company exists 25 years.
25 years.
I've met a guy that was a French doctor in Paris who did the first ventral hernia using a very, very old robot. Like you cannot compare what we are using now to what we had what surgeons had in the beginning. And I think that was like I think 20 years ago, more or less.
Was that the S? I think that was the S.
Yeah, I think even before the S, there was still something different. They have one at the Orsi, the really first ones. They look. Yeah, it's like an old IBM computer and a Mac, you know.
Yeah, because
it's the evolution. It looks nicer and it functions better.
Yeah, that's so there's the S, the SI, the XI. Most hospitals now kind of have upgraded to the XI, and there's other platforms that have come out too that are a bit tapered down. But at Cedars-Sinai, we actually had the S until I think a year and a half ago. It finally broke down, but we had it for like 10, 15 years. And it's like driving stick shift compared to an automatic. It worked fine, but it was definitely not as advanced as each generation. So there was one day where I had to be moved around for some reason because of the different rooms. So I did a case on the S, the SI, and the XI, and I could kind of see the evolution of the engineering going from stick shift to like fully automatic. It was pretty cool. Well, the urologist in the United States, 100% have switched over to robotics. There's some that are really good laparoscopic surgeons, but like the prostate and most of those operations are now done almost, I think it's like it's in the high 90 percentile, like maybe
Yeah,
96%,
98, I think.
98%. Yeah, something really crazily high done robotically. In fact, they almost don't even do as much laparoscopic. It's so interesting, like how as you train, technology takes over for the good of the patient, but then sometimes you need to, like sometimes you need to learn how to drive a stick shift and not just only a automatic. You know what I mean?
Yeah, well,
Yeah.
it's like for the people that are training now, for example, gallbladder, most of the people that we've trained in the last years, they've never seen an open gallbladder operation
Yes.
because the benefit of the laparoscopy is so big that you don't want to expose your patients to the older technique, being an open cholecystectomy. So being a little bit older surgeon, sometimes you get called in by a younger colleague because they know you have the baggage
Yes.
from the beginning of my training.
Yeah, I was fortunate to have been right at the cusp. So laparoscopy was introduced uh, in more advanced manner during my residency. So I still got to do the open appendectomies and open gallbladders, and then get introduced to laparoscopic hernia repairs and so on. I think I was among the first that brought laparoscopic hernia repairs to our county hospital in Los Angeles. But yeah, so theoretically, right now, robotic surgery, you're in the same room. So the patient's in the room, anesthesiologist, the nurses, you're physically there with the robot and the console. It's like a sitting chair. Um, is that something that's going to change where the surgeon's not even in the room anymore? Has that been a discussion?
Well, I think that when you hear the history of the Da Vinci robot, that originally it was the original idea was from the U.S. Army, where they were thinking about having a surgeon operate from a distance, so the surgeon would not be exposed to harm close to the battlefield, but could still take control and do operations a bit from a distance. Uh, I think it has been done, it has been tried, and it's possible. You need a very good network. I think you need a 5G network to do that. And I was told that once that happens, that it would be possible for me to operate patients from my home if needed.
Yeah.
It would be difficult to see any good reason why we want to do that, because you would still have somebody who is surgically qualified there to put in the trocars, to dock the robot. Well, docking the robot can be done by well-trained nursing staff or anything, but let's say the responsibility of putting in a needle, putting in the trocars, will probably not shift from a doctor to another non how do you call it, paramedic profession. I think there's still
Yeah.
the liability there.
Yes. So before the Da Vinci platform, there was, I think, was it Zeus? There was another
Yes.
robot, and that was the first transatlantic surgery where the patient was in Strasbourg,
Yeah.
and the surgeon came to New York and did a gallbladder surgery. But there was like this is way before 5G. I think it was about 20 years
Lad.
ago, 18 years ago, 15 years ago. And the Marisco was the surgeon, and he noticed there was a lag, because of the wiring. There was a little bit of a lag, so he had to adapt to the fact that what he was doing in New York was transmitted it was a successful operation, but there was a lag. And then in Canada is an interesting country because it's a huge amount of land, and there are people that live closer to the U.S. border, which are where most of the cities are: Toronto, Montreal, Vancouver. And then way up north, there are people that live there, but there may be no surgeon within hours. So there are surgeons that have dabbled in telesurgery where the patient is intubated, gets anesthesia way up north in Canada, and the surgeons in Montreal doing their procedure. I mean, that's kind of interesting, but
Yeah.
well,
what I would see is, for example, if you have a very delicate part of an operation, let's say another surgeon feels like this is beyond my competence, that you would be able to get like another surgeon from a distance do that small part of the operation. But that would be like very non-common to begin with. And on the other hand, there would be a surgeon in the room taking responsibility of that patient. But let's say I could probably do a TAR operation and certain steps of the TAR for somebody in the Netherlands, a surgeon there who doesn't have reached proficiency to do the complete operation, for example.
Yeah. Maybe COVID will push us towards that.
Yeah.
One of the questions was about older surgeons. So it's true that robotic surgery ergonomically is much easier. Hasn't been proven because there's actually one recent study that shows it's actually not that much better. But I personally had really bad disc disease where I need to have lumbar surgery. And during the time before my surgery, I was operating still. But if I had to do laparoscopic or open surgery, I was standing, and the amount of pain I was in was horrendous. Whereas the days that I had robotic surgery, oh my God, it was heaven, because ergonomically, the pressure was off my lower back. And from personal experience, I know that's easier. So there's a question about, now that some older surgeons should probably retire, is a robot going to make them less likely to retire because they can still do surgery? What are your thoughts on that?
Well, first, the ergonomic part, it is like that. And I think most people, if, for example, next week on Tuesday, I have 5 groin hernias and 1 ventral. That's my operating list. That's on the robotic platform. If I would have to do that surgery all by myself from beginning to morning laparoscopically, I would be broken in the end of the day. For example, the thing is that during, like for laparoscopic groin hernia repair, you're standing next to the patient and you're holding your instruments like this.
Yeah.
And when you are operating, most of the time you're so focused that you don't really feel anything. But the moment you move away from that operating table, I broke my knee during soccer many years ago. My knee would always hurt, for example. And certainly if you're going to do a long list like that, unless you have a resident that can help you and do large parts of the operation, so that your scrubbing in is like 15 minutes, 20 minutes. But if you do the whole case, which is like 45 minutes completely and one after the other, then in the end of the day, you are completely broken. So that's true. Will I work longer? Because no, I don't think so. I think you have to look at it differently. If the surgeon abuses his body less during his work time, he will be able to enjoy much more his retirement because he has less physic complaints. So we could look at it like that as well, the well-being of the surgeon, even after his surgical career.
Good for you. Yeah, I totally agree. I think the surgery is such a physical career. It really has a toll. There's a lot of occupationally induced hazards and injuries that we get, spine disease being one of them. But surgeons who have a shake or tremor, that can be overcome by the robot, because a robot will fine tune that and get rid of your tremor. So in some ways, there is that added benefit, right?
Yeah, I see a lot of people come and visit me and do case observation, like it's called. And if they come from Scandinavia, for example, from Norway, and they try to make the equation, let's say, for example, in a country like Norway, the fact that it would ergonomically be better for the surgeon itself, which would be considered in that hospital like an employee, how you call that in English, somebody who works for the hospital.
Employee, yeah.
And yeah, that would be taken into account of the value proposition. And that might cost a little bit of money there, which probably in France or Spain, if the surgeons would try to complain and say that because of their better ergonomics, this should be taken into account into the cost value proposition, that would be laughed away. So there's a cultural difference. Certainly in Scandinavia, they ultimately, I think if you would take the cost of the robot away, there's no reason not to do every laparoscopy with the robotic platform. There are some things like a little bit bigger trocars, things like that, but in the end of the day, for me, if I would have all-time access, I would do all my groin hernias laparoscopically with the robot.
Yeah, with the robot. Yeah, definitely for the surgeon, it's also very easy on our body. So that's a good segue on the next question, which is presented live, which is this patient is currently in the watchful waiting protocol for their inguinal hernia. And he says, part of me is thinking if I can hold out long enough with a small and manageable hernia, maybe when I absolutely have to get it repaired, there will be newer techniques with lower risks of complications, such as for chronic pain. How far away do you think we are with newer technology? And is there anything in the horizon you want to share with us? Where do you think we're headed? Is there better non-mesh repairs, better robotic techniques, semi-biologic mesh, and so on? What are your thoughts about the horizon of inguinal hernia repair in the next 5 years?
Watchful waiting for male patients is a sensible approach. If you have a small, I know a lot of people, including myself, who have a very small groin hernia. I would never get it fixed because it doesn't hurt me. I know it because I'm a surgeon. If I would not be a surgeon, I would not even be aware of it, probably. The likelihood that it will grow and at one point in my lifetime I will need surgery because it will start hurting and it will grow is high. But the risk of waiting is not substantial. So the risk of having complications like incarceration from the watchful waiting is not huge. I would not expect the technology mesh-wise or technique-wise to change so dramatically in the coming decades that it would be something that you would wait for. My ultimate dream is that with artificial intelligence, I would do 1,000 operations. The robot would learn how I do a groin hernia repair and I would operate myself.
Oh my God.
You understand?
Yes, I do. That's nuts.
Because I think that ultimately when you want to go for surgery, quality depends probably more of the surgeon that operates you. How often do they do this operation? Absolutely. Are they really interested in it? Do they call themselves a hernia surgeon, or are they general surgeons that do groin hernias only infrequently? There are papers from the Netherlands where some surgeons do 5 groin hernias a year. Ultimately, this will probably reflect in their outcomes. Luckily, it's only 5 patients that are at harm. But if then you look like people like me and probably also you who are doing maybe 500 a year, that's a big difference. And of course, in the end of the road, nobody's perfect. There will always be a small chance of having chronic groin pain. The selection of the patient is very important, I think, also for chronic groin pain. We see some patients that are very nervous, very afraid, and even when you they have a small groin hernia and they have some pain in the groin, and you want to investigate them. You don't even touch them; they already move away.
Yeah.
These are people at high risk for chronic pain because they
Yes.
probably have a sensitivity in that groin that is at risk. So in such patients, and I try to avoid proposing them surgery. If there are female patients listening, watchful waiting for females usually is not recommended because female patients show up with a higher frequency with incarcerated hernias. And so usually a groin hernia in a female patient, the advice probably should be to have them propose a repair, although they might have only mild symptoms. Is that also your attitude? That's what I think that comes out of the guidelines more or less at the moment.
Right. So it's important to note that all of the watchful waiting trials were done on men only exclusively. So we don't know the data for women, and we know that women are more likely to have femoral hernias. So if I have a patient that, and femoral hernias are not appropriate for watchful waiting because of the higher risk of complications, including death due to incarceration and sepsis. So I agree with you. If there's a female, I want to always make sure they don't have a femoral hernia. If they don't, I do push them in the watchful waiting arm if they are minimally symptomatic and are hesitant to have surgery. Understanding that we don't really know the data for women. I would think, though, that the future is bright. And I feel that we're kind of in a situation right now where, and this is my opinion, there's an overuse of mesh and there is an underpopulation of hernia specialists. Um, so, like you said, like in the United States, any general surgeon can do a hernia repair, but there are very few of us hernia specialists, very few. In fact, I would say like real specialists that do 100% of their time hernias, I would say less than the number of fingers in my hand. Um, those that do a lot of hernia surgery, maybe less than 50. Uh, so that's a very small number for a big country. The same is probably true in Europe. So we are, though, having an uptick in people interested in hernia surgery as a specialty. And so with time, we'll have more people doing hernia surgery as a specialty, and therefore outcomes should be better. And also the technology, I think the technology is shifting away from overuse of mesh and looking at better tissue techniques. I think, like, for example, we published our results on outcomes of robotic tissue repair. That's appropriate for really small hernias. There are newer meshes coming out that are less inflammatory, less synthetic, more of a hybrid mesh. And then there are actually newer sutures coming out that are less, more stronger, more tensile, less inflammatory, less of an issue with mesh reaction or suture reaction. So we're slowly getting there. It's a slow process, but I think we are moving in the right direction overall. We have another question, which is related to, we talked a lot about the pros of the robot, but as with any technology, there are risks. So what do you explain the risks to be associated specifically with the robot?
So for the biggest risk, I think, because as we told you before, when you do laparoscopy, you're holding the instruments in your hands. With the robot, usually you dock the patient, so which means that you're connecting the instruments to the robot. But then sometimes the instrument has to be removed or changed to, for example, first you use a scissors and then you use a needle driver.
Yeah.
If somebody is doing that incorrectly, that's, I think, a risk that is specifically associated to the robotic platform. So there's a very important aspect of learning and teaching people that are, they call it the bedside assist. So the person, which is usually a nurse or a surgeon in training, that is standing next to the patient and taking
Right.
instruments in and out. And that's probably one of the risks associated specifically to the robot. I've done now in these 4 years about 1,000 cases, more or less, and I have not had any risk specifically related to that. But it takes a little bit of military discipline, certainly if you have new people in the OR. Like we have a lot of trainees that move around. If they are at the robot for the first time, you really have to drill them and say, you're not moving anything unless I tell you to. Of course, if this is a nurse practitioner next to the patient that is you've done like 100 operations with that nurse, you know, they know how to do these things, and you can be a little bit less strict. But certainly when you have new people, it has to be more like a military drill type of atmosphere.
Yes.
I call it, which can be relaxed after a while, but
I agree, and I think there is a certain group of patients that are very adamant against the robot. They feel the robot is dangerous. Um, I would say it's like a car. You know, if you don't know how to drive a car or like a fast car, then yeah, it definitely can be dangerous. And what had happened with the robot's introduction, what I understand is there were multiple serious complications of bowel injury noted by introduction of the robot to the gynecologist, which was actually before it was introduced to the general surgeons, was urologists and then gynecologists, because working in the pelvis it can be difficult laparoscopically. And there are not a lot, there was a large percentage of patients that had unacceptable injuries. We don't really see that anymore. We have really improved a lot in education. Do you have, I know the United States, it's probably the same in Europe. There is a very strict protocol as to the education of a surgeon before they're allowed to operate on patients unsupervised with the robot. What is that?
yeah, I think that's something. I do a lot of training. I've in these 4 years I've went to, I think, about 60 hospitals across Europe,
Yeah.
Where I started up, and I must say that Intuitive does a very good job at taking these people through a training pathway, trying to avoid them doing clinical cases before they're really proficient with the robot. And I must say that it has not happened to me that I went in for a clinical case that I found that the surgeon was not well prepared.
Yeah.
It has happened that surgeons choose the wrong and too complicated cases as their first cases, but they were well prepared how to work the robot, how to move the instrument, how to move the camera. So because the surgeons are usually first they do online training, then they have to do simulator training. Like if you're a pilot, you have to do a certain amount of hours,
Yes.
which I recommend is about 24 hours, trying to work with that instrument. And then usually surgeons are taken to a lab where they do a cadaveric training and a simulation of an operation before they move on a clinical case. And when they do the first clinical case, almost 100% of surgeons are assisted by a proctor, which is a surgeon that is like me, that has come to proficiency and is there just to. And most of the times when I'm there, at the end of the day, I say, why was I here? I was not really needed because the surgeon was able to do that. But I think for a surgeon, certainly doing his first clinical case on a robotic platform gives them a certain anxiety and just having somebody there who's done it so many times and has the experience just helps you to relax and to do that first operation. And the end of the day, for anatomy reasons or for technical reasons, often certainly because most of the time it's a groin hernia. When you look at hernia surgery, you're not really needed there because most of them are already proficient in hernia surgery. They just have to learn how to work with that platform.
Right. And I think that the company has learned the importance of education as part of their rollout of their platform. Um,
I
you know,
think
with
that's a
lap,
bit different what I'm like, say, second generation or third, whatever you want. I've only went on the robot 6 years ago when already robotic surgery penetrated the general surgery people in the US to a high degree.
right.
So probably lessons learned there were taken seriously, and I do have the feeling that in Europe uh, they take that very seriously, and they're doing a good job.
I agree. In the last few minutes, can you share what you know about the next generation of the intuitive platform of robots? I know there's like a single port and some other potential offerings coming. And then what do you know about other companies that are also entering the robotics market? Johnson and Johnson, Medtronic. What do you know
So
about?
the uh, the Da Vinci platform indeed has a new thing. It's not available in Europe. I think it's available in the US already. Maybe not nationwide, but certainly at certain centers. It's called a single port.
Yes, we have
Where
that.
the cool thing, it looks very cool. It's probably also very expensive with it because it's not interchangeable with the robot you already have. And
Correct.
all instruments and the camera go through one trocar, so you have only one incision, which is bigger. It's I think it's 2.5 centimeters, so it's bigger than the other incisions. But that I think certain indications will show up where it's going to be a good platform. Not sure about hernia surgery. We don't know. Might be. Uh, what else they have in the pipeline, Da Vinci, you usually don't know before it enters the market, because most of
Yes.
this research and development is a bit sealed off from the eyes of the competitors. In Europe, we have since I think since this year we have the CMR robotic platform, which is called Versius,
Yes.
and some centers in Europe are starting to work with it. It has some features that are different from Da Vinci. We know that the Da Vinci, of course, is an evolution of 25 years. The Versus robot is the first generation, so there probably will be some features that you have with the Da Vinci which you will not yet have with the Versus. It will be interesting to see, and we think and we hope that competition, of course, will drive a little bit down the costs also for the users, the hospitals, and the patients. And there is another robot, Senhance, which is around for a few years, but that technologically wise until now has disappointed me a little bit. It was you could call it more a very expensive laparoscopy because it didn't bring enough of the advantages that you have with the Da Vinci platform. But also they might change. They do research and development. That was their first generation. So there will be competition, and there's some big players like Medtronic, Johnson and Johnson, but rumors are rumors since I don't know 5 6 years.
Yes.
They keep being rumors. So it's the many of these big companies. They say, okay, we're big. We have a big company. We will be able to provide a new robot in this short amount of time. But I think they underestimate the difficulty how Da Vinci and Intuitive worked for 25 years, coming to that level of machinery, like we could call it, of technical superb machine. So that's probably the reason why it's not. But it'll come in 5 years. We will probably have several companies competing each other. It's like Gore Jewel mesh was the first mesh for placement in the abdomen, uh,
Yes.
which was like 15 years ago. Now you have like I don't know a whole bunch of them. So
Yeah.
so competition will come, and some might be better, some might be. There will be a selection, but it's difficult to make a robot as good as the Da Vinci Xi for sure.
Yeah, none of them. I've tried many of them, and they try and improve on some things like the haptics, but even that's not so far hasn't been good enough. All right. Do you have any parting words? So that if not, this will be the end of our hernia talk together.
Yeah, okay. I would say stay safe because we are not in the best place of the world at the moment, COVID wise.
Yes.
But okay.
Well, I hope you all stay safe. I know Europe is having a little bit of a surge. There's certain areas of the United States also were surging. So November, December are going to be difficult times from a infectious diseases standpoint. I hope everyone stays safe. And on that note, I want to thank you all for taking your time today. It's election day in the United States. I hope everyone's voted. Thank you, Dr. Muysoms, for offering us your time. And I hope you go back. Your lovely doggy was in the background. It's very cute to have him as part of our guest. And this will be posted on YouTube for everyone to rewatch and share. Thank you for following me on Twitter and Instagram at HerniaTalk and on my Facebook page at Dr. Tofi. As I mentioned earlier, Dr. Muysoms can be found also on Twitter at Filip Muysoms. Thank you very much, and hope you have a good night, Filip.
Yeah, I will.
Thank you. Hope to see you soon in person.
Yeah.
Maybe in
Bye.
Denmark. Bye-bye.
Yeah.